Welcome to the fourth of five presentations put forth by the Park City Hip and Knee Foundation. My name is Tom Bradbury. I'll be moderating tonight's events. By way of background, the Park City Hip and Knee Foundation was established about 5 years ago in 2015 as a forum for exchanging orthopedic knowledge. Obviously, I think we would all prefer to be together, sharing our experiences in caring for patients, and the pandemic has thrown a monkey wrench into that. And so we're doing these lectures on an online format through these webinars. With that, it's an absolute pleasure to introduce Dr. Orhun Muratoglu. And Orhun is the director of the Harris Orthopedic Lab at Mass General Hospital. And I think if you look at his CV, you'll start to realize that a lot of the things that have been done in the arthroplasty world that have really made a difference have either been a direct or an indirect influence of Orhun's work. That includes cross-linked polyethylene. It includes a variety of antioxidant treatments and technologies. And with that, I'm going to turn the podium over to him for his discussion on cross-linked polyethylene, past, present, and future. Orhun, welcome.
Thank you, Tom. Thank you for the nice introduction. We're going to talk about the state-of-the-art polyethylene, past, present, and future. These are my disclosures. In 1995, polyethylene manufacturers actually abandoned gamma sterilization in air and started to sterilize components in inert gas to avoid oxidation. In 1998, radiation cross-linking was introduced to improve the wear resistance of the polyethylene. In 2007, we started to use antioxidants to further stabilize the polyethylene against oxidation. And now we are trying to eliminate the need for radiation cross-linking and using chemicals to do the cross-linking with. And currently, we're also working on trying to deliver a variety of therapeutic agents, including antibiotics, from polyethylene. And in the future, we're likely to see a number of combination devices made out of polyethylene. Now, let's go back to the landscape in early to mid-1990s. The number one problem was periprosthetic osteolysis, especially in the hips, generated by or initiated by the particulate debris that comes from articulation of the femoral head in the polyethylene. And this debris then would be taken up by macrophages, and a cytokine storm will occur, just like it does with COVID-19 patients. And that storm results in resorption of bone around the implants, and the implants become loose and necessitate revision surgery. Another problem that was related to polyethylene was the oxidation-induced changes in the mechanical properties, embrittlement of the material, and delamination. And we set out to solve both of these problems in early 1990s. And what we found is that radiation cross-linking does improve the wear resistance of the material. You can see on the left-hand side with the graph, as we increase the dose and we increase the cross-link density, the wear rate precipitously drops. We developed simulators, hip and knee simulators, as you see on the right-hand side, and these machines were used to collect the preclinical data that was needed to submit the for clearance to FDA and other regulatory agencies around the world. These implants made out of highly crossing polyethylene were cleared, and their use has increased quite fast in the hip and a bit slower in the knee. This is fresh off the press from the Australian Registry 2020 report. These numbers very much reflect what happens in the rest of the world. As you can see on the left-hand side, almost 100% of hips done today use one form of a highly crossing polyethylene. There's a very small percentage of a fraction of ceramic and metal-on-metal articulations, but the majority of them are highly crossing polyethylene articulating against mostly ceramic and some metal heads. And on the right-hand side, you see that the knees are increasing as well. And the latest number is approaching 70%. I think in the United States, that number is about 75% of the knees done today are using highly crossing polyethylene. So let's take a look at the outcomes a little bit. This is again from the recent report from Australia. As you can see, the cumulative percent revision after 19 years of use is substantially reduced when the acetabular liners is fabricated from a highly crossing polyethylene. Take a look at this a bit closely. What you see here on the left-hand side is the conventional polyethylene. There's a lot of loosening that's related to periprosthetic osteolysis, And there's also some report of lysis that's reported into the registry, as you can see on the left-hand side. With the crossing polyethylene, the revisions are much lower in rate, and also loosening is no longer a prominent reason for revision. And the lysis has come down quite dramatically as well. And what remains as the biggest problems in hips, of course, is infection and dislocation. If you look at the knees, again from the Australian registry, these are the recent numbers. At 17 years of use, the cumulative percent revision is again substantially lower with highly crossing polyethylenes in comparison to conventional polyethylenes. And when you look at this closely, what you see here on the left-hand side with the conventional polyethylene, again, loosening is a major reason for revision, followed by infection. And with the highly crossing polyethylenes, now loosening is much less in occurrence, and the infection becomes the number one problem in failure of total knee replacement surgery. Another interesting finding, this comes again from the Australian registry, where they looked at over 300,000 total knee replacements and found that there's a 25% less chance of infection when highly crossing polyethylene is used in comparison to conventional polyethylene. Most likely, the reason for this is related to the inflammation that is caused by the particulate debris when conventional polyethylene is used. That inflammation reduces the local neutrophil function, and the neutrophils are needed to kill the Staph aureus. And when the immune system doesn't have access to the neutrophil as much, then the infection rate is higher with the conventional polyethylene. So it's good to see that this actually plays out in patients as reported and demonstrated by this registry data. So with the first generation crossing polyethylenes that we developed in the mid-1990s, we achieved excellent outcomes in hips and knees. And but now we're asking the questions of what happens in the second and third decade of use, and what happens to the outcomes with young and active patients. Could there be any in vivo changes to polyethylene that could potentially compromise the performance of these devices? Well, what we found is that there may be two things. One is cyclic load or stress-induced oxidation, and the other one is lipid-induced oxidation. So when you look at the lipids in the synovial fluid, there is abundant presence of squalene, which is a precursor of cholesterol, and this molecule very readily diffuses into polyethylene. It's a pro-oxidant, and in the long term, could cause oxidation and changes in the properties of the material. In fact, in the laboratory, when we diffuse squalene, I call it just as lipids here, squalene into polyethylene, what we find is that the oxidation levels are much higher during an accelerated aging experiment. The same is true when we subject the polyethylene to cyclic load during accelerated aging. Again, the oxidation levels are higher. Now, what we did was in early 2000s, we decided to put an antioxidant into the polyethylene. In this case, vitamin E, as you can see the molecule up here. It's a very strong antioxidant. And in the presence of vitamin E, you can stop the oxidation that is caused by lipids. You can also stop the oxidation that is caused by cyclic loading. So we were able to achieve a material that most likely is going to be very, very stable in the very, very long term, second, third, and if needed, fourth decade of service in vivo. And there's some early data now from patients. This is from our studies looking at RSA, quantification of penetration of the femoral head into the acetabular liner, which represents linear wear into polyethylene. You can see with the black line is the conventional polyethylene with 28 millimeter heads. It's a steady wear rate. With the first generation highly crossing polyethylene and the blue with the same head size, there's some bedding in early on, but then the curve is flat, indicating that there is no detectable wear. Now, the same is true when the vitamin E is present in the polyethylene. We don't expect anything to be different here. There's some bedding in, but then the curve is flat. Even with these larger head sizes, the wear rate is not compromised in the presence of vitamin E. The new method of cross-linking that I mentioned earlier is the peroxides. And now what we're trying to do is we're trying to see if we can actually eliminate the need for radiation cross-linking and replace that with a chemical method. In this case, we're blending peroxide powder with polyethylene powder. We're adding vitamin E. And then this blend is consolidated, and simultaneously it is cross-linked. So there's no need to cross-link it with radiation. Subsequently, we subject it to high temperature melting, and that helps us in increasing its mechanical properties. When you compare the peroxide crossing polyethylene on the lower row here to the first generation and the second generation antioxidant stabilized polyethylenes, what you see is that there are some advantages in terms of mechanical properties, and the wear rate is not compromised. So we can safely use peroxide cross-linking and vitamin E stabilization instead of using radiation cross-linking. So with the highly crossing polyethylenes, we were able to achieve high wear resistance, high oxidative stability, and we've successfully eliminated, I should say maybe minimized, but I think we've eliminated periprosthetic osteolysis secondary to particulate debris in total hip and total knee patients. We've also achieved an unexpected outcome, that's the reduced infection rate with crossing polyethylenes. And of course, with the improved wear rate, we can use larger heads and reduce the dislocation in total hip patients. Finally, I will leave you with this thought. Dr. Harris and I have looked at the U.S. Potential savings with the use of highly crossing polyethylenes, and we came up with the magical number of $1 billion every year savings in the United States with crossing polyethylenes in total hips. You can double that for total hips, total knees in the U.S., so that will be $2 billion of savings, and globally that will be $4 billion of savings with the use of highly crossing polyethylenes. Thank you for your attention.
Orhun, fantastic work, and I think it's fair to say that we're all looking forward to the results of newer technologies. Hopefully, we can circle back with a couple of questions at the end of the section. With that, we're going to transition to Hany Bedair, who currently serves as the director of the Joint Replacement Center at Newton Wellesley Hospital, just down the road in Boston. And Hany is a busy clinician and is going to talk about a novel femoral head design and its use in total hip arthroplasty.
Terrific. Thank you so much. Thanks for the invitation to talk. This is always a great couple hours. So I'm going to talk about this contoured femoral head. This is also an innovation out of the Harris Lab and Orhun's group. I have no conflicts or disclosures with respect to this, but certainly the MGH and the lab does for the intellectual property related to this. So we've always thought that the incidence of groin pain after a primary total hip arthroplasty was less than 10%. Now, a recent study by Nam in 2018 really showed that regardless of the approach, the incidence of anterior hip pain was close to 20%. It was 19% for anterior hips. It was 24% for posterolateral hips. And, you know, I think some of it makes sense when we talk about large femoral heads, hip resurfacings, malpositioned cups. But for well-placed components, conventional size heads, what seems to be the problem? We see these patients all the time. You know, these folks come in and they say, well, it hurts when I get out of a chair. When I try to lift my leg, I try to get in and out of the car. It really kills me. It hurts right in the groin. And you can reproduce this on examination. So certainly there are clear reasons. If you malposition the cup and the anterior flange is prominent to the anterior wall, that can happen as the iliopsoas drapes over that. That will hurt. Some large femoral heads can cause this problem as well, and certainly that's probably related to cup position and aversion of the stem. And several authors have talked about this. Yoshio did a nice cadaveric study showing that when you extend your hip, your psoas tendon drapes right over your femoral head. And so you imagine if there's a prosthesis there or a sharp edge, that would really cause you some trouble. James Brown did this nice case report, basically converted a patient who had a large metal-on-metal femoral head who was having anterior groin pain related to iliopsoas impingement to a conventional 36 millimeter head, and that resolved that patient's pain. And you can imagine if you drew sort of a line where the iliopsoas tendon was and drapes. Sorry, that that sketch misses, but anyway, you get the idea. So smaller volume of material in that compartment. So one of the ideas is, you know, could you shape a femoral head to sort of cut away the areas of material where you really don't need it, and hopefully reduce the volume of material in the joint, and hopefully reduce the impingement of the iliopsoas tendon. So that was the idea of this contour head. You take a 36 millimeter head, as you see on the left there, and you sort of cut away the areas you don't really need. It tapers pretty quickly after the diameter, after the midpoint of the sphere. So here's a cadaveric study. The wire is the iliopsoas tendon. the ball is sort of draped in a mesh of wire, if you will, and that's a conventional ball. And you see the tendon is incredibly close to the femoral head. And if you use a contoured head, you see that decompresses that anterior compartment a little bit, gives that iliopsoas tendon a little bit of space. So conceptually, and at least in a cadaveric model, it makes sense that perhaps this would help. Now, the question always comes out, in orthopedics is, are we solving a problem but creating a different problem? So is this new femoral head going to create wear problems, trunnion problems? Are the femoral heads going to explode in the hip? Are we going to have high rates of dislocation? So this was a finite element analysis. This is sort of pretty typical for these types of studies. You model 3 types of activities: walking, knee bend, chair sitting, and you model the acetabular femoral component in a lot of different orientations. The left is the contact and high pressure peak points for the contoured femoral head, and it's essentially identical to that of the conventional 36 millimeter head. So doesn't seem to be generating any increased peak forces on the polyethylene. What about wear studies? This is wear by weight, so essentially volumetric wear. In the cross-linked polyethylene and the vitamin E polyethylene Orhun just talked about, which is the blue and teal lines at the bottom, the contoured head and the conventional heads perform exactly the same over 2 million gait cycles. So no problem, at least as far as we can tell, with wear with these contoured heads. What about stem engagement on the trunnion? Are we going to create problems with trunnion and trunniinosis? Well, trunniinosis, it turns out that the bite, the region where the head actually contacts the trunnion, doesn't really seem to be different between the two, and that clearly is an intentional design feature. What about pull-off strength? It's the same. The contoured head is on the bar on the far left, and different types and combinations of conventional femoral heads on the 4 right bars. It's essentially the same. What about burst strength, and how much force does it take to shatter one of these femoral heads? These are paired bars, so the contoured is on the left, and the standard is the bar right next to it. And you see with different head sizes, 28 millimeter heads, 32 millimeters, and then 44 millimeter heads with 12-14 tapers. The burst load is exactly the same essentially between the contoured and the standard heads. So it doesn't seem to be any significant problems with the heads fracturing. And this is kind of the big one. What about hip dislocation? So we've taken away a lot of material from the femoral head. Are we going to create a problem with dislocation? As you saw from those graphs, dislocation is one of the major problems currently. So this is a modeling profile, and we looked at 3 modes of hip dislocation: just straight flexion, internal rotation, and external rotation, and extension. And it turns out that the dislocation rates between the contoured head and the conventional heads aren't really significantly different. And I'll show you why. It turns out that the arc and the area that articulates with the head with the poly is about the same. And it's the same until you hit the impingement point on the neck, which then you start to lever out. And then you might ask, well, what about the jump distance? Well, it turns out that the jump distance is essentially identical. We looked at 3 different modes. I'm reporting 2 modes here: dislocation mode A and B, which is the internal rotation, and then combined flexion and adduction. And the dislocation rates, jump distances are the same, or nearly the same, for the conventional and the contoured head. So I would say that we're trying to solve a problem here that seems to be bigger than we think it is. I don't think that we're introducing any new problems. We don't see any increased peak loads on the poly. The wear seems to be about the same. The head engagement on the trunnion seems to be about the same without any significant risk of fracture. And the dislocation rates are nearly, or we would predict to be nearly identical to conventional femoral heads. So currently, we were sort of embarking on a clinical study. We got derailed by the COVID crisis, as most of you know. All things have been kind of thrown into chaos, but hopefully we'll get back on track, and it'll be interesting to see how this pans out. So thank you so much.
Hany, fantastic. Looking forward to hearing a little bit more about that, especially as that study gets online and gets some more information on it. With that, we're going to transition to Dr. Hofmann. I'm 13 years deep in my career, and I'll tell you, every time I hear Aaron talk, I learn something, which is what I really, what I really enjoy. But what I enjoy more is I laugh every time I hear a presentation from Dr. Hofmann. He is going to fill us in on porous fixation and total hip replacement, which behind cross-link polyethylene, I think is probably the second biggest thing to change the quality of people's lives that are having these surgeries. And Aaron, thanks so much.
All right, thank you very much. I'm going to be talking about porous total hips, which I don't know how much new information you're going to hear, but anytime that there's a new device out there, and what you're looking at is a device that's been around for almost 10 years, and everybody wants to know, what's the clinical track record, and has there been something promoted on this? And so when we started out with hip replacement 30 years ago, there was a lot of things that we didn't have, and we didn't have the highly cross-link polyethylene that Orhun was talking about. Almost none of us were using a ceramic ball, occasionally, but of course, with the increased price, nobody wanted to use a ceramic ball. So this is basically the construct that we're using, and I'm going to just talk a little bit about the history, my history going back 30 years. So certainly when we're talking about hip replacement, let's not forget about templating. And so I can't imagine now doing a hip replacement without templating at first, knowing what the neck cut is, how to restore the center of rotation, how to get leg lengths to be the same. And so, the general concept is to template the femoral side on the most normal, least involved side, and template the acetabulum from the deformed, worn side, trying to figure out what that is. So this takes me way back here. This is one of the first acetabular components that I had the pleasure of patenting in 1991. And so the concept was to have a hemispherical flare, having something that was a stretched hemisphere is what we call it now. And it turns out if you start measuring all the acetabular components that are out there, they all have a little extra stretch around the perimeter. And the reason for that, if you work backwards from how thick the polyethylene has to be at the perimeter and at the depth of the hemisphere, the only way you can keep and maintain the thickness of the polyethylene at the edge is to have a little stretch around the perimeter. So even though most companies don't talk about that, if you start measuring acetabular components, they really are all stretched a little bit. And we were lucky enough to get a patent on that, which has obviously since expired. Okay, so basically the idea of a stretched hemisphere is to have a 1 millimeter press at the perimeter. So you get more press at the perimeter than you do at the bottom of the cup. And this really more closely matches the anatomy and footprint of the acetabulum, I think. So this goes back to the natural hip. I know we're not supposed to mention names here, but this one is taken off the market. So I guess you can mention something if it's no longer marketed. But it was an extremely popular implant. I know some of the orthopedic surgeons I operated on as patients, actually, if they had the left one done, they bought the right one and have it on their shelf so that they can have the same matched implant when the time comes. All right, so basically here's the basic concept. If you just look at something that's just a little bit more than a hemisphere, and the diagram on the lower left-hand side demonstrates that. So there is a small amount of stretch that starts at the apex of the component and then has the same radius of curvature out to the end. So bottom line is that you can get and maintain polyethylene. And so for this, the implant that I use and the current implant designs that the FDA approves, you need to have 5 millimeters of peripheral polyethylene anywhere. It's easy to have thicker polyethylene if you just pull the liner out of the acetabular component a little bit, then you get the depth at the bottom, but to keep the depth at the perimeter means a little bit of a stretch, and that's what we did. So there's just an example of one of these implants at 6 years, and I'll show you clinical results that we have from that. So this is what the porous coating looks like. It's, remember some of the meetings we went to 10 years ago where you had some of the porous coatings and they made pins out of them. You could stick the pin on your lapel that had the very sticky Velcro-like porous coating. Well, those coatings somehow over the years have gotten kind of squashed. This one is not squashed. This is a very aggressive porous coating. It's 60% porous. you know, 150 to 400 microns of the pores. It's a millimeter thick. And the FDA requires 2,000 PSI pull-out strength of porous coating. This happens to have 5,000 PSI, and it is animal proven. So there have a lot of porous coatings out there that have no animal data. One of the notorious ones was the Durham cup that came from Switzerland. It was a chemically etched material that was put out there in the market. And if you know the history of the Durham cup, which turned out to be a metal on metal implant, that actually got recalled and there was no ingrowth. In fact, it's not a three-dimensional coating. It was just a surface etching. So a porous coating has to be three-dimensional. It can't be just plasma sprayed. Even HA spraying kind of blocks the porous coating. So if you want a true porous coating, it has to be 2 or 3 layers. So it has to be animal proven. So the sheep is the best model now. This is me operating on Barbara here. That is Barbara. And this sheep actually died in the recovery room. I was told by the veterinarian helping with this study that he would do the rest of the sheep without me. So animals, it turns out, don't do very well on their back. But the idea was to put porous plugs in the distal femoral condyles, similar to what we did years ago at the VA hospital with our patients that we were doing another experiment on or with, and looking at porous coating. So you do tetracycline labeling and you retrieve these specimens at the end of 3 months. And this is what it looks like. It was amazing, the ingrowth that this porous coating has. And this is what you have to look at, whatever implant you're using at. What's the track record of that porous coating? What's the implant retrieval? What is the animal data? So this particular one that I use has got cobalt chrome and titanium with 46% ingrowth into that porous coating. So these are the implants that I'm using. So it turns out that one implant does not work all the time for every case. So I know that Keith Berend is talking about a blade stem. And so if I have a tiny little canal, I'm going to use a blade. If I have a type C bone patient, I'm going to use the stem that's seen on the left-hand side. It's a more square looking thing. I actually was operating with a surgeon in Las Vegas on Monday, and he called it the door stem. And that's because it looks very much like the first stem that Dr. Dorr worked on, which is very square looking. And so it is a square peg in a round hole, which has unbelievable rotational stability, especially for C bone. And that thing, I think, allows you to put a press fit into C bone and never have to cement a stem. So I haven't cemented a stem in the last 20 years, except for a patient with cancer. Otherwise, that stem can really lock on in any kind of bone. So just to look at our own clinical results with this particular stem, and again, this is a C-bone patient 6 years after implantation, 81 years old. I've done 400 of these, not that many probably over the last, this was at 6 years, and we actually, I'll show you in a paper just a minute, that has minimum 5-year follow-up. Everybody wants to know what's the clinical results, and so we wrote a paper on that. Actually, one of the fellows wrote the paper on that. As we know, fellows do all the work and we just put our name on the paper. That's the way it's supposed to be, correct? So no loosening, 0, 2 dislocations, 1 infection, and then 1 revision that I'm going to show you gave us a chance to look at this porous coating. So this is Jeshua Law, who's in Modesto now, training residents, spent a fellowship time with me and also in New Albany as a fellow there. Great guy, loves to write papers. And so he looked at all the hips that we did with the minimum 5-year follow-up and wrote up this this particular study, which I just gave you the highlights of. So it did allow us to look at what this porous coating is looking at. I mean, we love to have implant retrievals. Years ago, I had patients sign consent to give their implants back after they died, and we were able to get 25 knee implants, porous knee implants, and write many papers on that. And so this was a chance to look at this particular porous coating 2 years after implantation. Talk about psoas impingement, that's what this patient had. And I tried everything short of operating on this patient, trying to get this thing to settle down. And finally, you can see how much of that cup is sticking out. And maybe it was the size of the femoral head. certainly had psoas impingement. We were able to get the cup out, and you can see the amount of porous coating that is in there. And I think I have one slide left. So this was the revision we did. Again, it gave us the opportunity to look at an acetabular component. We just deepened it and solved the psoas impingement problem. So in conclusion, porous hips work. I think we all know that. It works in all types of bone. One implant doesn't work, I think, for all types, but certainly in B bone, C bone, this implant here called the HD stem is a great one. And the basic concept of porous implants has a 30-year proven track record with stable and reproducible results. So thank you very much.
Aaron, thank you. All right, we're going to transition to giving the podium over to Dr. Berend, who's going to talk about blade stem designs. And when I think of a blade stem design, the first thing that comes to mind is efficiency. And when I was training, we were transitioning from a Riemann Broach kind of system that was probably a major market shareholder to more efficient designs. There's a bunch of iterations of this style of implant on the market. As Keith does a ton of surgery and has a lot of experience, I'm interested to hear on how he goes about choosing the blade that he uses in his practice. Keith, welcome.
Hey, thanks, Tom. Appreciate that. We're going to get started with the presentation. So it is important. My conflicts are with a small and joint development, which has IP and development efforts that go into design of one of the stems we'll talk about. So a little bit like Tom was saying, for almost 40 years now, the idea of a tapered stem has been around. And each one of these stems that's shown here, this is from an article that Dr. Mallory published from a scientific presentation at the Academy in 2001 called Why a Taper. And the bottom line with Why a Taper is that they work really well. And if you go from left to right on this screen, you see kind of a wedge, a Riemann Broach, Riemann Broach, Riemann Broach, Riemann Broach, broach only, and then a square broach only that kind of is a design of its own in this Zweimüller. So each one of these designs bear at least one thing common, and that's that they're tapered in at least two dimensions. And one of the interesting things was, just like Tom, my early experience in practice during fellowship and in practice was with Riemann Broach stem and the Mallory head. And if you look across these stems, the Mallory head is kind of the longest and the most complex geometry of these stems. And it was that because, as Dr. Mallory said, we were using the laboratory of life. And we really wanted to fail in the early 80s when they produced, and it didn't fail. We've produced plenty of studies that show % survivorship in all sorts of different patients. One of the big issues with switching from a Riemann Broach, very bulky, very complex stem, to a broach only, what I'll call a wedge stem, as opposed to a blade, but a two-dimensional wedge stem, is the issue of periprosthetic fracture. And I think those of us that have done a lot of these realize this is the drawback, particularly, as Dr. Hofmann said, in the door C bone, where perhaps a different complexity of geometry, such as a square, might be beneficial. I'm going to hope to show you that a blade or a three-dimensional taper may be beneficial as well. But this is one of our series, our first series, where we were alarmed by a 1% risk of fracture using the approach and a wedge type tapered stem. We looked at about 3,000 stems over a 7-year period. Gender was far and away the highest risk factor for these fractures. We then controlled for BMI, the type of stem, and controlled for both. And gender was still the most significant risk factor for fracture. The length, as you see on this catastrophic picture here, whether it was a short stem or a standard length stem, was not actually a risk factor in this study of about 3,000 hips. Now, we then looked at a larger cohort and ferret out the differences between these different stem designs. So if you look here, you've got a short stem, then you've got a long stem with reduced distal. You've got, under the black arrows, a standard profile long stem, and then again, a reduced distal profile stem, where you can see the porous coating and the reduction hit at the same level in order to not pot that stem in a door A or a door B bone. And that's a 15 millimeter with a 3 millimeter reduction in the distal interface. But if you add to that the distance or the thickness of that porting, it becomes a 4 or 5 meter difference between hip and that offset. And what we wanted to look at was which of these variables was the reason for the fracture, or could be associated with, perhaps not the reason, but could be associated with fracture. And what we found was, looking at almost 5,100 hips in the series, the fracture rate was a little bit lower, but still pretty high, almost 1 to 100 at 0.3. And if you look at that full profile, full length, so the bulkiest, highest kind of stem within any bone, the fracture rate was 0.33%. If you look at the small stem with reduced distal taper, so the smallest stem loading the top of the femur the most, because it's reduced distally, as you see in this on your right, the fracture rate was over 1.25%. BMI was not a factor. Age continued to be a very significant factor. See here, and female gender was also a significant factor. If you controlled for the age and the gender being the most significant factors, the use of a reduced distal, smaller stem also significant with an odds ratio of almost 4. And so what that showed us was this concept of a dual taper wedge type stem had a fracture risk if you're trying to use it in women, in elderly patient, or if you're trying to use a smaller stem for whatever reason versus the kind of standard profile stem used for 30 or 40 years. So our experience at JIS Orthopedics, both myself and Dr. Morris have used what we call aid stem. We'll talk a little bit about that. Here's a bilateral hip series that you can see here with arthritis and a pretty good reproduction of often length with the blade type stem slide. As of a couple days ago, we published this last year, and what we looked at was a triple wedge broach only stem. Slightly different geometry than what I presented before with a wedge type stem. This is more of a triple wedge or a broach only stem. It also, to me, importantly, has a pended smooth medial transition where there's no step from the reduced distal. We looked at about 300 hips, minimum follow-up of 3 months, which is when these periprosthetic fractures occur. Age was 63, about half female, and we had 0 fractures. And so we felt pretty comfortable looking at our first 300 hips, 0 fractures. Mike Morris and I just looked back at our first 100 blade stems between 2 surgeons, all with the anterior approach without a fracture table, all with minimum 3-month follow-up. We have 1 fracture now in 100. This was a high energy fall from height. It was a multi-trauma. The stem was found to be ingrown time. We had 2 side, neither were revised, and we had no ASF loosening or no other revisions. The way I will note is in those 600 slides, TJO has donated 60 stems to Operation Walk during that time frame, which I think is important to understand. And so looking at our data, or at least my practice data and Morris's data, we come up with a couple of conclusions. So when we looked at our most wanted list, we came up with the blade design. We wanted broach only. We wanted it to be shorter, which in this case means just a reduced distal tip, which eases insertion and in all sizes of bone. That triple wedge shape, I believe, is important as opposed to just a double taper. A medial transition to prevent a high stress area in the medial calcar. Standard and high offset needs to be available. I now, after about a year of experience, feel that Ontura heads are a very big benefit to using this particular device. And then I really feel that giving back is critically important, following in the steps of Dr. Hofmann. And this particular implant design produces donations of implants for Operation Walk, and that's important to me. So that's what I look for in a blade stem. Thanks.
Keith, great talk. Thank you. Hany, there's a question in the Q&A panel specifically about I guess it's the volume of articulation of the Contura head against the poly versus a traditional head. And the question was, is it the same, or is there a reduction in the surface area of that head versus its equal sized counterpart with a completely traditionally round head?
Yeah, that's a great question. It's the same, and it's the same until you reach the impingement point where you start to lever out. So it's 183 degrees, and so you sort of articulating the same as you would with a conventional head. And then the break point is when they start to lever and you get head neck impingement. So there's no less sort of articular contact area with the contoured head.
Great. Orhun, is there any other bearing couple that we should be using? I mean, should we get rid of all this other stuff? I will have a conversation with my patients that are less than 30. And unfortunately, I have a good friend that's a pediatric orthopedist, and he tries some fancy osteotomies, which inevitably fail, making conversion to a total hip difficult. And these young folks, I will talk to them about ceramic on ceramic, the mindset being is that it's oxidatively stable, and it's a good tribologically, it has very low wear rates. It of course has risks of squeak and risks of fracture. Should I bail that on that? I mean, do you think we have enough data to say we've got enough data now that we ought to eliminate other bearing surface options from our practice?
I think that the data is very, very strong now. There is data from young cohort of patients showing no periprosthetic osteolysis at 15, 16 years of follow-up. And I think the crossing polyethylene has solved the periprosthetic osteolysis problem in hips. Now you can use large heads, so you don't have the dislocation problem, not as much as you do with the smaller heads. And with vitamin E, I think that we've demonstrated in the laboratory, and now slowly we're coming up to 7 or 8 year follow-up and showing that there's absolutely no oxidation that's happening in the polyethylene. Even under super aggressive aging conditions, you cannot oxidize the polyethylene that is stabilized with vitamin E. And so I think that when paired with the ceramic head, probably not a metal head, but a ceramic head, that's probably the ideal articular pair now. Ceramic on highly crossing polyethylene that's stabilized with vitamin E.
Yeah, it's hard to argue against it, no doubt. Yeah. Keith and Aaron, two quick questions for both of you. What % of your hips are you using a broach-only blade style stem? And in those that you are not using it, what makes you deviate from that? I mean, how many arrows do you keep in the quiver? And what is the femur that you're templating the week before you say, that's not going to work for a blade, I'm going to transition to something else? Sort of heard what Aaron's thoughts are, but want to hear yours, and then Aaron's thoughts on what % of patients he gets away with a blade.
So I template a little bit before, and the two things that make me want to make sure I have backup are if it is a door in a small female, the blade stem that I use, the neck length increases every 3 millimeter or 3 sizes on the stem. And so if I template and it looks like it's going to be a 7 or an 8 because it's a huge C, I'm totally comfortable using the, but it's going to end up too long because that's literally a +3 neck length to start with. And so in those cases, I will use a rectangular broach only stem that Aaron also showed, that the offset option, a shorter neck length. So it has more horizontal offset and less vertical offset, or less leg length. And so those are the only times that I would deviate blade stem at this point. I have absolute confidence in bad bone. And the only reason is it templates to a big stem in a short female that'll end up along with the blade stem they use.
Right. Yeah. Aaron, your thoughts. What % are you blade versus Zweimüller style square implant?
Yeah, I've kind of gone back to the square peg and a round hole. So I still use the blade on people that have small canals because it's just going to be so tight. If I wanted to use the HD stem, the square peg and the round hole, you have to have reamers available just to touch the distal canal a little bit to give it a little bit of a stretch. So other than that, you could use that square peg and a round hole, the HD stem on every patient. But I think, just like CDH to DDH patients, the skinny little canal, I mean, a lot of us will use an SRAM on those patients. So I don't think, it's one size fits all. So I will use the blade or I'll use the HD stem, especially on C-bone. So again, I have friends that want to cement stems. I just don't see us going backwards to cementing stems. It doesn't make any sense if you have, the implant that can solve it. I do want to make one comment about the squeaking ceramic on ceramic. So I recently saw a patient who was in his 70s and said, the only time his hip was squeaking was when he was having sex, and it wasn't happening that much anymore. So he thought it would be okay to not revise it.
Well, gentlemen, thank you very much. So we're going to go ahead and transition directly into the next section. So our first section really dealt with materials that we use, and the second section really deals a little bit more with the art of surgery itself and some techniques. And I'm going to talk to you guys about my experience with anterior hip replacement using a table. Okay, so these are my disclosures. There is nothing pertinent in this talk to my disclosures. So I remember reading this article. It's hard to believe that this article was published 15 years ago. And although Joel Mata was not, certainly not the first to innovate with anterior approaches to the hip, he certainly hit the market with a head of steam. And I was a resident when this article was published. And I remember reading it and being off the service and thinking about instability and how really instability was the one thing that drove both the patient and the surgeon crazy, because it's a rather traumatic event and takes an otherwise really good outcome and renders someone without confidence. So, you have a dislocation, the patient is literally terrified to even stand up, move, or do other things they need to do. And I remember reading this article talking about dislocation being the most common early complication. And then these are direct quotes that came from the remainder of the article, in which he said, no muscles or tendons are detached. It's a single incision through an internervous plane with no postoperative restrictions to motion or position. And then in that 450 some odd patients, he published his dislocation rate of 0.6%. I think I'd been on call and was in the ER every night reducing a dislocated hip, thinking there's got to be a better way of doing this. And then he publishes a picture of this table with a supermodel on it. And I'm thinking to myself, well, good Lord, who would not jump onto this? And so I got really interested in it in 2005. Again, the major interest really came from ideas and ways to make hips more stable. And if you think about innovations in hip replacement designs over the past 2 decades, the majority of them have either been focused on wear or stability. Big heads, modular necks, metal on metal bearings to increase sizes, so on and so forth. And a lot of that stuff really was geared toward the surgeon's fear of instability. And that's when I really got interested in this. And then the anterior hip marketing propaganda started shortly after that. The patient would drive down the highway and see signs that says this is a muscle sparing approach. It's more stable. You have a quicker recovery. You'll have less or no pain. The surgeon hears fluoro use helps with implant placement. Leg lengths are easily assessed and there's no precautions after surgery. So obviously the demand grew, and then people started learning, well, this procedure isn't quite as easy as we thought. And the table became a leverage point for folks to try to aid in exposure during surgery. So I'm going to focus on this as a kind of a double-edged sword. We're going to talk about the table as an ally, and then we're also going to talk about the table as an enemy. So certainly there's a lot of advantages to doing these surgeries on the table. It is a multi-purpose table. It's probably the best fracture table available on the market. It truly does eliminate a surgical assistant. You can use the table to avoid anybody else having to be on the surgeon's side of the table. It's very fluoro compatible, and it's very helpful with determining pelvic tilt as it relates to the pelvic incidence when someone is standing versus when they're supine on the table. It's nice to be able to use SCDs on both legs for DVT prevention, and it really facilitates tough cases, mainly the obese, and then femoral revisions, which is where we have really used this thing to help us. And then it really honestly also serves as a marketing tool. I don't know what's sexy about that picture on the bottom of the screen, but for some reason, people like thinking about getting on that table. I hadn't figured it out yet, but there's certainly some interest in that. So what about the obese? Well, the really nice thing is there's a saddle on a lot of these tables, and it allows the buttock to fall posteriorly, which enables you to get better access over the front of the joint. And when you couple that with a lifting mechanism that's pretty automatic and pretty easy to use, it makes getting femoral access much easier. Here's an example of how the table holds retractors for you. This is me on the operative side of the table. There's only one other person on the other side of the table, and you could actually get an automated retracting device over there and do these surgeries completely solo. And I know a lot of guys do that, but it's nice not having to have an assistant hold or maintain the leg. And this is another example of it. Instead of having someone across the table with this traditional posterior hip holding the leg so that the surgeon can do the operation, the spar does it for you. And this is the leg turned upside down so we can get exposure and access to the femur. And it really does reduce the need for surgical assistance. And what it really helps with, especially with revision cases, is exposure of the femur. And even with a small incision, if you use the table correctly and use techniques correctly, you can get, I think, in my opinion, I've done a lot of posterior hips and for years and years and years, did all my revisions posteriorly. And I'm starting to transition because I can get really, really good access on both sides of the joint from the front. I know George Giles is going to talk a little bit about that later. An example of an obese patient, this patient's BMI is 50. And I'll tell you, day in, day out, I'll do this hip from the front, from sun up to sundown, because it's easier. It's technically less demanding. And as a general rule, the patients do well, but they've got to understand they're at risk for wound complications. And I tell them there's a 20% chance you're going to have to either go back to the OR or have wound care to manage your wound after surgery. We've got all sorts of wound care devices, but certainly they need to understand that. And the funny thing is, these people hurt so bad, they really don't care. They need help. So I'm willing to take a little bit of a risk with a lot of these folks. Here's an example of fluoroscopy for tilt. The x-ray on the left side of the screen is a standing AP. What that patient's pelvis does when they stand up, and an x-ray or a fluoro image on the right side of the screen that demonstrates a different inlet. And so if we crank the pelvis on the right down to match the inlet of the pelvis on the left, the aneversion in that cup will essentially go away. So it really does help me a little bit. And again, we don't have all the information on this, but at least it's a measurable parameter that we can use to make decisions on how to appropriately anevert our cups. So this is an example of a revision hip, and using the table to your advantage and using instruments to get a blade stem out, and with proper technique, using the table and appropriate positioning, these implants will come out very safely and very readily from the front. And here's an example of taking a blade out, and with proper technique from the front, you can literally get these out with zero bone on the stem with the proper instruments and proper technique. The table is an enemy. Obviously, cost is an issue, and I'm not sure there's a way around that. I will tell you that it essentially pays itself off for some marketing reasons and for volume. And there's a maintenance issue. We've had all sorts of problems with tables in the past. We've had one catch on fire. We've had a runaway electric lift. That stuff you're not going to deal with if you're doing it on a regular table. There can be scheduling conflicts, and it does need a driver, but that driver's not on my payroll. So I need somebody to move the leg, and we have some strategies to do that and do it efficiently. You also got to understand that when you use these tables, as a general rule, you are blocking your ability to really assess femoral version. And so you got to be really careful with that. And you also have some limits to appreciate impingement anteriorly with combined flexion and internal rotation. Certainly you can flex and adduct the hip, but it's a little bit tough to see sometimes. So this is an example of a hip I did 10 years ago. We did her from the front. I put her stem in a native version, and she dislocated while she'd cleared therapy. She was getting out of the bed to get to the car. She actually dislocated in the hospital. And I took her back to the operating room, reduced her, couldn't figure out what was going on, and took her back and actually opened her up from the back. And that's an SROM component that I revised her to. And you can see the sleeve at the bottom. Her native femur actually had 70 degrees of aneversion. So when I used a blade stem for this patient, she was an outlier. She had too much combined version. She came out the front and she required a revision. So I learned a lot from that. And several years later, we looked at using plain x-ray as a means to finding version. And this is just a slide showing what the native population has in terms of femoral version. So if you think everybody's built in at 15 degrees, you're wrong. Although that's the mean. Ranges are everywhere from 17 degrees of retroversion to 48 degrees of aneversion. And so we have found that this x-ray in patients that you're clinically concerned about version is very helpful. It's quick, it's easy, it's a plain film. You sit a patient on a stool, put their thigh parallel to the ground, abduct their leg 30 degrees, and shoot a PA view of the femur. And you can see the condyles and you can see the femoral neck, and it's much easier than a CT scan. I'll be quite frank with you. When I'm trying to match CT scan slices up and measure the angle, this is just more true to life to me than that. So if someone has excessive rotation of the hip, either extended or flexed, I'll get this x-ray to make sure they're not an outlier. Here's an example of that. This is a lady with old Perthes disease that had a bad hip. She had an incredible amount of aneversion on exam, even though her hip was terrible. So we get a Boudin lateral view or modified Boudin view, and our aneversion measures 55 degrees. So I'm not going to take that person to the operating room and put a blade in, because I'm essentially going to be locked into that version. So we're going to switch stem designs and use something that's easy that allows me to control version, and that's been very helpful for us in our practice. Table or not, you got to know the techniques. The key with this technique is proper capsular and short external rotator management. The slide on the right shows the anatomy. There's a couple of dots there where the short external rotators insert. The red dot really is the key. That is the obturator externus. There are very few hips that you cannot do with this technique without preserving that tendon. You should be able to preserve that tendon in the overwhelming majority of cases. That serves as your restraint and patient's physiologic feedback that their hip is going into too much internal rotation, and I think they protect themselves. And then don't forget about the nerves. We have had some experience with this and published our experience on it. The slide on the right shows the anatomy of the femoral nerve in the iliacus and the ilia capsularis. I am a big fan of using an anterior retractor because it allows me to protect the anterior wall of the acetabulum. But unless I can define the interval between the iliocapsularis and the hip capsule, that retractor does not go in because that retractor can injure the femoral nerve. Here's another example of a complex hip we did. This gentleman is 2 years out from this surgery. This is one of those stems. You got to know what you're getting into. It's a fully HA-coated stem. It's bonded from top to bottom. We decided to do a single stage exchange from the front and through a wall osteotomy that preserved the entire ring of the proximal femur, we were able to get access to the implant, completely burr the implant free from its integrated surface, extract it safely, wash his hip out, put a new hip in, and get him on his way. So we've been very pleased. And the table actually is very helpful for these types of procedures because you have a lot of assistance with positioning of the leg. So with that, thank you. And we're going to transition to Dr. Sam Wellman, and Sam's going to talk about posterior approaches to the hip, which truly is still the gold standard. It's the most expansile approach out there. And my recommendation to all fellows that are going through an adult recon fellowship is be a master of the hip from the front to the back, and excited to hear Sam's talk.
All right, thanks, Tom. So it's still, I think, the gold standard. No real disclosures relevant to the approach. So it's really great in just about every way. I'll talk about the dislocation thing in a minute, but you know, you can have one approach and just do everything, and you don't have to think about it. I know anterior approaches can be extensile. I think it's probably easier to extend a posterior. Whoops, I'm not doing that. It is, I think, probably easier on the abductors than other approaches. It's a nice place to put an incision for skin healing. Certainly have heard more talks about sort of fancy wound management in anterior incision placements than for posterior. And it doesn't make any difference what stem I use. They're all equally easy. And I kind of like using the straight tools instead of the curly cues. It is boring and everybody's heard about it and nobody wants to talk about it. So that's the main downside. I think the dislocation is less of a downside than it once was. I think, as we've talked about, there's cross-link poly allowing large heads. We have more offset options. I think increasing understanding of, you know, how much aneversion is the right amount of aneversion and combined aneversion, safe zone issues along with the lumbar spine. And I think also the focus on the posterior repair have changed the numbers compared to what we traditionally heard and experienced maybe as residents. So I think, you know, we actually wanted to look at this. Does the type of posterior repair matter? There's some data out there that's pretty old comparing no repair to a repair. And clearly this favors repairing something. And there are single surgeon technique type papers that, you know, show good success with various techniques, but really no comparison papers. And I sort of, you know, I changed my approach. I originally was repairing the capsule through drill holes to the greater trochanter, and then I switched over to a direct side to side. I call it an anatomic repair at the end of 2015. And after a while, I noticed it seemed like a difference in my dislocation rate. And so we did a retrospective study, but here's a little bit of the technique. So I'm not sure if this is important, but I do take the short rotators off the capsule as a separate layer. So that's the obturator internus and the piriformis peeled off of the posterior capsule. This is a right hip, and we use a cob or something thin like that to elevate the minimus off of the hip capsule, or that cobra was actually under the medius before that. Now it's under both abductors. And we're just looking at the posterior superior part of the hip capsule here. Here's the capsulotomy right down under the head, basically in line with where the piriformis was. And that's where the repair is going to come back, is right just directly side to side again at the end. There's a little more of taking this down. I do end up taking, a decent amount of the quadratus down as well. Seems to be in slow motion now, which sometimes feels that way. Anyways, a nice shot at the acetabulum with the straight reamer, really no problems. And when you want to get to the femur, you just kind of internally rotate. Everybody's seen this, it's very easy. Put a femoral elevator or a buttock depressor, as it may be, in. Yeah, this is definitely slow motion, sorry. Anyways, here's the repair at the end. This is now, unfortunately, a left hip. We've switched. And you can see, wow, that's really jumpy. Anyways, it's a direct, just usually 3 sutures, side to side repair, and it kind of just cinches right around the femoral head and neck. And when I started doing this, this was actually something I picked up from Dave Delury at one of the Emily Berend meetings that we host in Durham. And I really didn't think it was going to make that big a difference, but it's made maybe an enormous difference. But this is just the rotator repair to the greater, to the abductor tendon, which hasn't changed. So we actually wrote this up. Nick Hernandez, one of our fellows last year, along with some of our residents and med students here. So 841. Now these are my numbers. The numbers in the paper are a little different because of the exclusion criteria, but basically the same take-home message. I had, a 2-something%. I think it was actually a 3 in the paper because we excluded some people who didn't dislocate. But basically, with the old repair through drill holes to the greater trochanter, there was 2 to 3% dislocation, and since I switched, there's basically 0. There was one guy that dislocated the first day I tried it, who turned out to have Ehlers-Danlos. We eliminated him from the paper because he had connective tissue disorder, and it has persisted to the point where I'm no longer quite so superstitious talking about it. So I'd say, there's actual fake news out there. Is the DA recovery really that much faster? A lot of the stuff seems to be like visual analog scores in the first, day 2 or something like that. And really, once you get to about 6 to 8 weeks, no one can seem to consistently show any sort of difference. There is some evidence that DA is associated with early femoral failures. I think that's fairly well accepted. Less muscle damage. I don't really know about this. People ask me all the time if I have to cut their muscles, and say yes, but it's okay. And fewer dislocations. A lot of these studies are small, and admittedly, I just showed you a small study of my own, but looking at registry data, it seems like the difference between anterior and posterior approach dislocation rates is becoming sort of asymptotically similar. And in the Michigan registry study from a few years back, they were both about the same. And so it's not just that they're equivalent. I think there are actual real issues with these anterior approaches. And, a lot of the people on the meeting tonight are true experts at this, but a lot of the people doing these are not. And we know from the recent Mayo Clinic data that there's really, really serious morbidity of taking people back within the first year for a fracture. And I would ask, why are we suddenly hearing so much about all these? We really need to cement more stems and fracture rate and uncemented stems. I would argue the stems haven't changed much in the last several years. If anything, they've gotten a little better. What's changed is more and more anterior approaches. Finally, just updating this talk, I looked at, there was something in JAMA, which was from an Ontario joint registry. And most of the people in this study had a lateral approach. I think it was 70% lateral, 20% posterior, and 10% anterior. And this was actually fairly recently, 2015 to 2018. But when they matched DA patients were actually younger, healthier, a little bit, than their matched cohorts. And they had a 3 times higher risk of major complications. And interestingly, they were also had their surgeries done by much higher volume surgeons at higher volume centers. So it's kind of a setup for success, and it didn't really turn out that way. So I say, go with the Southern approach or go home. Thank you.
Sam, thank you. Great talk and certainly pertinent information. And I think, this may be the 7-year orthopedic cycle. I hear an increasing number of people say exactly what you're saying. Give me what works best. And if they don't care, then do what works for you. With that, excited to hear from Mike Morris and his experience with doing the anterior approach off of the table and its pros and cons.
Thanks, Tom. So we'll talk about the anterior approach without the table. Here are my disclosures, none are pertinent to this particular talk. A couple of things before we get really into it. Sam, I agreed with most of your talk. We could probably talk about this more in the discussion too. I think one of the biggest, it's not the approach necessarily, is how we're treating patients post-operatively. We've really gone away from restrictions. I can remember in training, we kept people partial weight bearing with a walker for 6 weeks. Now people are coming off their aids quite quickly. We're asking the implants to do a lot more these days. I think that's probably the biggest factor, and not necessarily approach. There are some stem variations we can talk about too that I think make a difference. But with that being said, we'll leave that for the discussion. I think Tom hit on it. The table is certainly sexy. There's no question about that. Here in New Albany, on the bottom of the screen, it perhaps is not so sexy, but it's efficient, and we've made it work, and we'll share our technique on how we do it. The other thing I think really needs to be mentioned is, we go to these meetings, now we're Zooming on these meetings, and I agree with, Sam philosophically. We spend a lot of time talking about the approach. This is what's been touted as the operation of the century in the Lancet by Learmouth. And we talked about Bill Harris a couple times already tonight. He described total hip replacement as one of the most successful of all surgical procedures for the management of end-stage human disease. So I think we really need to highlight this is an incredible operation that really benefits our patients. However you do it, you need to do it well. And you've heard from expert surgeons, and Tom and Sam are certainly expert surgeons, and they can do it quite well either through the front or the back. So we've heard lots of pros and cons about anterior versus anterior surgery. It's more dangerous, it's less dangerous, more blood loss, there's less blood loss, goes on, but it has to be done well. And if you do it technically well, it could be done safely. And I'll share our data with you. So my indications for total hip are the same irrespective of approach. I think challenging hips are not exclusive to the anterior approach or the posterior approach. I think we would agree that BMIs north of 50 can be challenging due to soft tissue issues, regardless of the approach. I think proximal femoral deformity with retained hardware has its own challenges, severe protrusio. The short varus neck in the mesomorphic males has its challenges, as well as severe dysplastics. This is our basic setup in New Albany. Upper left slide, we're working on the patient's right hip. You can see it's shorter than the other side, and he's got a pretty sizable contracture there. Prep both legs into the field. This allows us, compared to the table, to have free range of motion assessment of the operative limb during the operation. So we seal off, it's the right hip in this particular case, we seal off the right hip with the IABAN drapes. And then we get down to business. So the anatomy is internervous and intermuscular. Superficially, you'll see on the bottom left-hand screen, the purple hued muscle is your TFL, and we're going to incise that fascia. Just north of that there, or medial in real life, is your sartorius. You want to stay out of there. That's where your lateral femoral cutaneous nerve is going to be residing. But you have to be careful of some of the branches that sometimes cross over the field. So we're going to open up that fascia over the TFL. We're going to move it laterally as shown in the middle picture in the lower portion of the screen. This is a right hip, by the way. And you've got to deal with the ascending branches of the lateral femoral circumflex vessels at this point. cauterize them, tie them off, whatever your choice is. And then you put the retractors extracapsular around the superior and inferior neck. The superior neck is to your left, the inferior neck is to your right, and then there's a skinny retractor on the acetabular rim once you elevate the rectus. At this point, you can do either a capsulectomy or a capsulotomy. The retractors then go intracapsular, and then you're staring at the femoral neck as evidenced in the bottom left-hand portion of the screen. We do a napkin ring cut of the femoral neck and remove that with a Steinmann pin to create a little bit of space. And then the femoral head is removed with a Steinmann pin. I think the important point here is not to drop your hand for visualization purposes. That'll leave a large posterior portion of the femoral neck, which will impede both acetabular preparation and exposure, as well as femoral exposure. At this point, the cup is pretty straightforward. Debris to labrum in any fights. For exposure purposes, we ream under fluoro. Place the cup under fluoro. As Tom mentioned, you need to be careful of your pelvic tilt and rotation. And just because we're using fluoro doesn't mean we throw out our osseous and soft tissue landmarks. We want to use those for confirmatory checks. The femoral exposure is probably the big thing with this approach on the regular table. It's sort of we use a table mounted hook, not to rip the femur up out of the wound, but as a fulcrum, and as a lever arm to put some tension on it as part of our release. The real bulk of the work is done by a skilled assistant, which is our physician's assistant. So it's a gradual titrated release. And the release starts in the saddle of the trochanter as depicted by my terrible drawing up on the upper right. And we work away from the cut neck to the edge of that saddle. The abductors are on the outside of that saddle. It's all capsular attachment on the inside of that saddle. So if you stay on the inside of the saddle, you're not going to injure the abductors. So the foot of the table is dropped 45 degrees for this, as well as about 15 to 20 degrees of Trendelenburg. And through adduction, external rotation, and extension, with this titrated release, we can get the femur up out of the wound, and then it's preparation. You can use a brooch, you can use a Riemann brooch, you could put a revision stem through here, and it's pretty straightforward. At this point, confirmatory checks with the trial. I think one of the things that Tom mentioned as a downside to the table, we have full range of motion of the operative limb. We can check for both impingement in the front and the back, and make sure that thing is stable. And we use fluoro as well to confirm our leg lengths as well as our final implant. Closure is pretty straightforward and efficient. And as I had mentioned, these patients are treated, weight bearing is tolerated, initially with a walker, progression to a cane, and then off as their symptoms allow. So some of our data, not all inclusive, but some of the things Dr. Berend initially presented on his learning curve. I will make mention that, I mean, you're talking about an expert surgeon that took on this endeavor. And his learning curve was approximately 37 cases. We have shown, compared to a less invasive direct lateral, that we have had quicker recoveries. The length of stay has been shortened. We have shown that outpatient surgery is feasible and safe. I think that's not irrespective of approach. You can do direct laterals, you can do posteriors, and still have patients going home the same day. We've also shown in a randomized control study that bipolar sealers are not effective at reducing transfusion rates, but I could tell you that they're very helpful, especially in large patients where visualization might be difficult. We don't use them routinely on all cases. Transfusion rates in general have gone down significantly since the universal use of tranexamic acid, and sitting at 0.1% now. Our overall complication rate, 1.7%, as Keith mentioned. Our periprosthetic fracture rate, we've reported in multiple articles, just under 1%. Everyone damned the anterior approach as the cause. Indeed, it's probably more stem design, at least I've not seen it published, but Mike Bolognese shared his experience with this same stem that we saw with the 0.9% fracture rate, and his rate was almost identical. So it's probably not the approach. It's probably the stem design more than anything. And quite honestly, how we treat the patients early on in that first 6 weeks. There's our dislocation rate and our infection rate. We have shown, as Keith mentioned, a much better success regarding the periprosthetic fracture issue with a triple wedge stem design. So I will close with saying, why do it through the front? So I think the decision you need to make, and especially for the young folks out there, is what's most reliable in my hands. And the reason why I do it through the front is not marketing. I know where the components are. I know how stable the hip is. I know what the leg lengths are, and there's zero surprises when I get to the when a patient gets to the recovery room, and it's reproducible in my hands. So those are the big things on why I do it this way. Thanks.
Mike, great talk. Much appreciated. We're going to transition directly into Dr. Braley's talk. I think, Houston, you've become world renowned for your expertise on management of periprosthetic fractures. I've seen some of your x-rays, and it's a work of art. So I'm going to turn the podium over to you and looking forward to picking up some pearls.
Awesome. Well, thanks for having me again this year. It's really a pleasure to be able to talk, and with such great faculty. So we're going to talk about periprosthetic fractures of the hip, tips and tricks, kind of the top 5. I'm going to be on time. I've got a pretty short slides. I think I'm pretty consistent with that in the past. We'll keep it up. Again, periprosthetic fractures are becoming a major cause of revision, and some papers showed in the future maybe up to the 3rd leading cause of revision, mainly due to the elderly age, osteoporosis, and some of the potential for the osteolysis from older polyethylene. In addition, I think it's something definitely to have in your wheelhouse, and it's good for the young surgeons, especially starting out, to really become familiar with soon and fast, because I think it's going to become more of an issue later on. And I do want to echo Keith Berend's comments about periprosthetic fractures with blade stems, and we've done some finite elemental analyses in our laboratory with Phil Noble, and come some really interesting evidence of blade stems, especially placing them in varus and having the kind of a tomahawk effect on the calcar, and also the distal aspect kind of hitting through the lateral cortex. It's pretty substantial, especially for an A and a C, specifically with a varus stem. In addition, when we're implanting or impacting our femoral head, it shows a significant stress riser in those areas, which is kind of interesting. You wonder if it's just popping on the head at the end, you think it's all done, how much does that actually cause a split rather than just putting down the femoral stem itself, because of that torque you're having if you're not hitting it straight on. Anyways, I'll start out with the preoperative imaging. I think this is one of probably the most important things we've learned. Having the largest trauma center in the nation, we almost get all CT scans on everybody coming in, and we get 2mm cuts. The important thing is this, and we get it with a metal artifact reduction for our CT scans, which we have available at 2 of our hospitals. This helps you to, 1, determine the extent of the fracture. How far distal is it? Where do you need to put a prophylactic cable? So you don't want to get in there, not see the x-ray, or not see a CT scan where you know that there's a fracture extending distally. All of a sudden, notice that you're splitting your femur more distally. Now you start dissecting the vastus, and you keep going and keep going and keep going. This gives you an idea relatively where, and you can measure this specifically on the coronal, where that extent lies distally. And that way you can just elevate the vastus, put your prophylactic cable, and manage the soft tissue safely. I think that's a very key important point, and I'll get to that in a minute. Pre-op films, if available, leg length, loosening, ability to template the distal stem with good x-rays in clinic if you have it. Try to get it. Look into your old PAC system. You might have them from the hospital, from previous partners, or even if yourself. I think that gives you a little bit more information. Always have the opposite hip to template. But a lot of times when these people are coming with periprosthetic fractures, they might have loosening on the contralateral side, especially for old cemented stems, so those are relatively unreliable. Hardware, this is your workhorses. I really like the periprosthetic contoured plates, locking plates by one of the companies. If you look at the top right, you have the NCB plates, which are, I think, just key. They take really care of, especially the proximal aspect, taking care of having the trochanteric claw plates, which I just get so frustrated with, trying to get the 2 tines, trying to mount that in. You're splitting the trochanter. Is it really in the bone, or is it just enough to get into the abductor to hold it on there? And it's just, I feel like it's unreliable. So a great solution are the proximal aspects of these plates, which you can lay on there, and then you connect. If you look at the third plate down, this will connect onto the top portion and become a fully locking plate. These are all locking screws, and there's also cortical or non-locking screws that you can help reduce the fracture. You really don't need to do that because it comes a locking construct and really gives you the ability to place cables through the plate, locking and cortical screws. And so you can also use different types of, whether you want to use Kinemed cables or your standard cables. Also your modular tapered stems. Of course, the Arcos is the big workhorse for me. You have all the options. You got the 150, 190s, and of course the, I think 240s you have for the ETO stems. When you get those Vancouver Cs, you really want that ETO stem. You're basically reaming with a 150, then adding on a curved proximal body component. And those are definitely the workhorse and have great success with those. Your tools, again, top right, whenever you have a quote unquote loose fracture, a B3 or a B2, there's going to be some bone left over on it. It's usually the lateral trochanter, sometimes on the medial calcar, but it's still not stable. That's the only thing maybe attached to it, but you want to preserve that. So I'd recommend having these radial blades, some of the curved ones to get around the lateral aspect of the trochanter, also the calcar to really save what bone you do have, so you don't split that, and you'll be able to have it at the cable back. Verbruge clamps are great too to help spare that bastus. You don't have the standard reduction lofter clamps that you're having to crank over 90 degrees, tearing the bastus. This gives you a great option there. Multiple reduction clamps, holding multi-fragmented B3s together is great. I like the cables. Kinemed's very strong. Problem is you don't see it necessarily on X-ray, but it is a very strong cable. It's double wrapped and then do like that. And of course, your standard large frag segment pan. Soft tissue handling, I can't emphasize this enough. I think this is probably the most important thing. You really got to manage the soft tissues, and sometimes you have to keep going, and because the split goes all the way down to the knee, and you got to put a proximal plate, you got to put a distal plate. You're basically reconstructing the tube to have anything to salvage with cables, and of course you have an allograft strut here. So you got to manage the soft tissues. I think that's definitely very important. Have a bipolar aquamanus for all the vastus and the bleeding. Try to really manage the vastus, keep as much as you can intact. Try to elevate only that is what is necessary. A Provena and drain, still don't use drains. I don't think that's important except for just causing more blood loss. A Provena, love it on revisions, but then you know what? I hate taking care of it. And I started just using a Preniotate closure because those don't drain if you keep them on for 3 weeks. Tend to, but people can have allergic reactions to that. So I've started going back and forth between the using a Provena and just a standard closure. Allograft struts, a great complement, especially when you're missing some bone. It acts as a great strut. You can see on the far right, this was a patient that I had to supplement. That bone was chicken crap. It was terrible. So this was a way to lock in to the contralateral side for a big old prosthetic fracture. And also on the bottom left, this is well incorporated in. This is an old X-ray. A patient just followed up with me about a month ago, and that's all one segment. So definitely something to have in your armamentarium. Make sure you contour it and get down to bleeding bone for your native bone so it does ingrowth. Thank you.
Houston, once again, great talk. Lots of tips and pearls there. And with that, we're going to start the last discussion of the section. George joined our group several years ago, and I tell you about a total breath of fresh air. It's just been so nice to have him as a friend and partner. And with that, I'm going to turn the podium over to you and hear about your experience with the anterior-based revision hip arthroplasty.
Good evening, and thanks, Tom, for having me, and thanks to TJO for having me back for this riveting talk on revision DA hip. Hopefully I can get control of the screen, as some of you other guys have mentioned. Let's see here. There we go. So anterior revision total hip replacement, what next? Here are my conflicts of interest, which are not relevant to the approach. So question number one, Dr. Guile, do all of your revision anterior hip patients do great? The answer is yes, of course, except for my first anterior revision patient who told me the redneck word of the day, which is, why in hell did I get up so early today? This guy did not do that great. Question number 2 is, which of the following is associated with anterior revision hip replacement? Lower dislocation rate, decreased 90-day readmission, increased superficial wound complications, and equivalent PJI incidence. The answer, of course, is all the above. And those are some of the things we found when we published our study in JOA this year, looking at anterior revisions versus posterior, that we did indeed have a lower dislocation rate, but there was an increase in superficial wounds. This, of course, is a big topic, so we're going to move that and just start with a quick case example of a 56-year-old lady who came to see me with this infected right Wagner cone type of stem, and she had had a previous DA approach. And we were able to get out this well-fixed stem with an osteotomy from the front. So certainly these things are feasible, although typically it's this Wagner type of osteotomy. And she was a single stage exchange, and she actually left the hospital the following day. And you can occasionally hit home runs. I wish they all went like this, but certainly it's feasible to do this. One of the questions I get a lot is, what are your indication or exclusion criteria for DA revision? The short answer is any revision except a posterior column defect. If they have an up and out defect, you know, the money is in the back of the pelvis and you want to be in the back. Other than that, there are no femoral limitations and really no other acetabular limitations. So as an example of a limitation, I kind of, ask me how I know sort of thing. So this lady had a gross trunnion failure that I revised, and her cup actually flipped out 2 years after, potentially from necrosis. And I thought it was just going to be a simple cup revision, and I was not correct. So we were in the front and we had to try and get an augment on the back. And although she's done okay, and it's been a few years now, I would not encourage you to tackle these 3A cases from the front. It's kind of like operating upside down and backwards sort of thing. So if they have a problem with the anterior column, I think go in the front. Posterior column, I still would say go to the back. A few tips and tricks just for headliner pearls. As people do more DA approaches, eventually you're going to have to do these revisions. So why would you do this? Headliners dislocate at a high rate. It's been shown in other anterior-based approaches to be a lower rate of dislocation, but you have to know a few tricks. So in this case on a revision, the tensor is going to be adherent to the fascia, and you have to peel it off and kind of stay in scar. You're not going to be able to just bluntly sweep the tensor off with your finger. When you put your Cobra retractors or other retractors, it's going to be around a prosthetic neck, which is not as wide, and they can kind of collapse on each other. So you may have to actually put your retractors in more of an acetabular retractor position, one on the ilium and one in maybe the obturator foramen, to give you a little bit of wider retractor exposure. Dislocating these hips, if you try and dislocate and just hit the head ball off, it'll get stuck underneath the tensor. So you have to hit them off in situ and externally rotate the trunnion off. And then you just remove your liner with a drill and screw technique. The femoral component revision, the real tip I have here is to put the table in a lot of Trendelenburg and jackknife the table, drop the leg, and you can take down the tensor fascia, down off the ilium, and you can really get a straight shot on just very impressive body habitus type of people. So just doing those two little techniques, you'll get great femoral exposure. Be prepared to extend your incisions through this lazy S for periprosthetic fracture type of work. So just a quick case again, this guy came to see me. I always show this and ask the residents and fellows which side hurts. They always say the right side with the stem and varus, but actually was this HA coated left stem. You can see some cortical reaction there with a bone scan that lit up. Here's, reasonable exposure DA. I think there's a quick video here that will play. You can see how loose this stem actually was before I even touched it. So just amazing to me what people can tolerate. I know it was a DA revision, so you really can't get good femoral exposure here. For acetabular exposure, some of the same tips for the headliner. You know, I used to do a lot of large Gelpies. I'm doing a little less of that now. Have your standard explant osteotomes. For an isolated acetabular revision, it's all about understanding how to mobilize the femur, just like you would from a posterior approach. You still have to release, you know, the piriformis, obturator internus, superior capsule, so that the trunnion, you can kind of see it in this picture down below, the trunnion will fall away. So just like a posterior approach, you're going to tuck that anteriorly. In this case, you're going to tuck that trunnion posteriorly, and you do have to modify the leg position. You might have to externally rotate the leg or flex the hip up a little bit to get that out of your way. And I would just say, you know, if you do any hip resurfacing, this is something I've kind of gone back to doing, believe it or not. And just understanding how to mobilize the femur, doing an isolated acetabular revision is very similar to doing a hip resurfacing from the front, where you have to do those femoral releases. You know, in this case, you've got to get a much larger native femoral head out of the way so that you can ream the socket. And there's certainly some ways of doing that. The other thing I'll say, it's been a long time since I've done a cage. You know, you used to see these up and in defects where the, you know, anterior column and medial wall are gone. And these used to be cage type cases. For me, you can see how this cup is going to want to tip back into that anterior column defect. Here we are on the inner table on the front of the hip. And we're able to bolt these anterior column buttress plates onto the acetabulum, and this has been effective and safe way of doing this type of surgery for me. I'll just add, you know, in years past, they've said that the anterior approach was not effective, even for primaries, just in very rare conditions. There's been limited data in the past showing that these revisions have had no dislocations in the past. Other data has shown no nerve injuries. We've added a little bit of data with decreased dislocation rate. So I'll just say, not only is it feasible, I think there's some stability benefits. I think supine positioning helps anesthesia quite a bit. It has a low deep infection rate. I will opine that there is an increased superficial wounds here. And as Dr. Wellman mentioned, you know, sometimes you have to resort to some impressive wound management strategy here. This is my go-to for everything except the posterior column defect. And I'm going to leave you guys with that, and we can keep going.
George, as always, great talk. Would like to entertain a couple of questions for the panel. And obviously, you know, this anterior versus posterior versus lateral, which approach is best conversation comes up a lot. And I'm just interested in the panel's talk on that. There was one question on the Q&A session that was very direct and say, for the anterior guys, do you really think it's better than posterior? And I can give you my kind of 2 cents worth on this, is that I don't think these approaches are better than one another. I think they're different. I think there are different pros and there are different cons. And I think you need to be good at what you do. And I think that if I was having my hip done by Sam Wellman, I would want Sam to do a posterior hip because I know I would do really, really well. I'm not sure that switching approaches back and forth is really a tenable idea for a lot of people. But I think it's nice to be the master of both domains and be facile from both the front and the back, because both have some pros and cons. And, you know, I'd love to hear George and Keith and anybody else's comments on that. And then the other thing I want to bring up is the article, Wellman, that you brought up about complication rates with anterior hips, and just want to get some feedback from the panel on that as well. So anybody else want to entertain any comments?
Yeah, I think it's not just approach. You know, in the past, you'll read some of these papers, anterior versus posterior, but the real, what ends up getting compared, it's anterior approach with the assistance of intraoperative fluoroscopy versus posterior approach, right? And so that's to me the difference. It's not, you can argue about the, you know, fake news and muscle sparing and quicker recovery. That's usually not the conversation I have with people. To me, the real benefit is the facile use of intraoperative imaging. So I feel like I can restore leg length offset, cup positioning, et cetera, better. And the harder the case, the better it is from the front. if you got to remove broken hardware, nails, you're doing revision work with altered bony anatomy, the harder the case, the better it is that you have a quick and easy way to image that with fluoroscopy. Of course, that's possible posteriorly with flat plates. But to me, the harder the case, the better it is from the front. You can expose it and you can see it with imaging.
I think, not sure I completely agree with that statement, but don't disagree. Just not sure I completely agree. The one thing I wanted to say to Sam's reference to the JAMA article, which I think was in typical JAMA fashion, was published because it had, I think it was published because it had a controversial sort of bend. You do realize that while you compared it to your posterior approach, 70% of the cases in that article were done through the direct lateral hardening approach.
Yeah, I mentioned that.
Yeah, I know you did, but I just want to reiterate that you're comparing it to the posterior approach versus the anterior approach. You're comparing is the direct lateral versus the anterior approach, which is 70% of the cases in that article. We looked at 60% direct lateral versus 40% anterior. Complication rate, fracture rate, dislocation rate, and infection rate were all lower in the anterior approach in the hands of one. So I think it's important to say that if you're talking posterior versus anterior, apples to oranges, not apples to oranges.
Great comments. Last question for revision hips. Houston, Sam, Keith, Mike, are you guys deviating from your normal wound closure? Is there a go-to device that you found in these higher risk revision cases, especially hips? Can you share your experience with varying technologies that are available? Are you using more closed suction vac type devices? Are you using silver impregnated devices? What has been the strategy, and have you had success with one way or the other?
Yeah, I kind of hate to admit it, but I have gone to fancy wound stuff for revision hips, and you know, it's sort of years of our quarterly M&M lists, and the revision hips seem to be the real standouts in terms of where we were having wound or infection or whatever kind of problems like that. And so that's the one group where I made a change, and I've basically been doing, I don't know, for the past year and a half or two now, dissolving antibiotic beads and a wound vac, incisional wound vac on every revision hip. And some, you know, some of them are like head liners, and it's kind of like, well, it's not that big, but trying to be consistent about it. And it seems, and other people in our section have kind of done similar things, and it seems like we're talking about fewer of those type of problems now when we have our quarterly talks. So I have done that.
Yeah.
I think the important thing, you mentioned a couple of different distinctions of doing something fancy. A covering of sort like silver or gold or platinum or whatever is different than treating them differently. And what Sam said is a negative pressure wound dressing. And I think this is a vascular issue, not a contamination issue. This is a skin and subcutaneous fat issue. And negative wound pressure dressings increase vascularity and do speed healing. They're not a cure-all, but there's no question the studies show they're way better. Infection rate, wound infection, all the stuff with silver dressings, that's the cherry on the top of the sundae. We're talking about the ice cream and making sure you get plenty of vascularity. And the only way to do that is the negative pressure wound dressing.
And I second that. When I was talking about for the like periprosthetic, if a patient's very healthy and good tissue, not a lot of scar tissue, and it's a relatively small, painless operation, I tend to now go for my primary closure, keep a perineum on there for 3 weeks, peel it off, it looks beautiful. But for somebody that's a smoker, a cirrhotic, or somebody that comes in at 2 to 3 weeks, they start having necrosis, it's a perfusion issue. I tend to use staples because my dissolvable closure is going to start opening up at about 3 to 4 weeks, or like with the rheumatoid. So I'll have staples and I'll do a negative pressure wound dressing for that. And I found that to be more beneficial than relying on something that's going to dissolve and then I'm screwed.
And that's the issue with the obese patient as well. It's a polarity issue. It isn't that it's hiding under the pannus or that it's in some smoky district of town. It's a vascularity issue, and the only way to improve that is with negative wound pressure, not with silver or gold or any other chemical.
Yeah, lots of positive, reports with that wound management technique, both in the hip and in the knee. So, gentlemen, thank you very much. We're going to hear from some experts on their top 5 moves for hip replacement. We're going to hear from Bill Hamilton, who is certainly a thought leader with regards to hip arthroplasty and approaches. And Bill, welcome and thanks for joining us.
Thanks, guys. Really appreciate it. I got my new TJO swag on, and I'm ready to share a couple pearls. This has really teed me up nicely, because a lot of what I'm going to tell you tees into what you guys were just talking about. So disclosures are relevant to everything we talk about, some from diffuse synthes and TJO. So I'll give you a couple tips, and I'll try to make it quick. This is perfect. We were just talking about wound management, and I'm going to keep this all with the anterior hip. So I don't think there's any question for me. Wound complications higher with the anterior approach. So I'll show you my approach and a lot of what you guys were just talking about. 1, standard wound, thin patient. I use a sub-Q absorbable glue, Tegaderm, Telfa. These heal just fine. 2nd, wound gets bigger, a little bit of pannus overhang. I use a silver impregnated dressing. And when the pannus gets gigantic, like in this case where my hand is hidden and you gotta tape it, I go negative pressure dressing. So take home message, customize wound dressing for anterior approach, and you can minimize wound complications. My complication rate is under 1% with this approach. 2nd, femoral nerve. Tom Bradbury mentioned this. This is important. Now, femoral nerve palsies are rare, almost zero in posterior approach, but in anterior approach, they are present. Jay Parvizi, in his article in 2018, showed it does happen. He had a 0.4% incidence. Mine's a little lower than that, but I have had these. They are present. I believe this is a stretch injury because of the hyperextension in the anterior approach. And it is a fairly morbid thing when it happens. So I've made a couple of modifications to try and prevent these. First, I put a little hip flexion on the hip during the acetabular exposure, so that when I put the acetabular retractor in, it's on less stress. 1, I lower the table a little bit. I'm 6'2". If you're short, probably not as important, but if you raise the table up to your height and then drop the foot to the floor, that's going to be increased stress. Really careful retractor placement over the front and careful with hip extension. I think this is most relevant in short females because we know that the nerve is closer to the acetabulum and they have less room for excursion. So be careful. These are morbid complications when they happen. 3, we talked about this time and time again, but you got to place the parts correctly. And I believe it is now the standard of care to use some form of augmentation of placement. Using your eyeball alone, I don't think it passes muster. So I think I've listed all of the techniques on the left here, whether it's fluoro with software, a grid, robotics, some of these guides. I don't think it matters, but I think we need help in placing our implants for cup positioning, leg lengths, offset, and restoration of kinematics. Here's how I do it. I use fluoro with some sort of software. I've used a couple different products here, and this helps me to get the leg lengths better and the cup position. We published this a couple years ago, really last year. Now it's up to 2 years ago, but with some sort of on-screen software, 99% are in the safe zone and the leg lengths are on point. Last, this is something that was mentioned earlier, but type A bone, maybe the most problematic bone. We talked a lot about type C bone, but if your stem, whether it's a blade or a triple taper, I don't care what it is, but if you're getting caught in the canal when your stems are designed for proximal fixation, it is a recipe for disaster. I believe you have to have some form of reamer to open that canal so that you don't get caught distally and get your fixation where the stem was intended to get caught. and whether it's a blade on the left or one of these fully HA coated stems on the right, doesn't matter the design. If this happens, it can be problematic for loosening and thigh pain. And lastly, I would argue, if you're Sam Wellman and you are talking people out of the anterior approach, that is good for business because patients want this. And this is the 2020 AAHKS annual practice norm survey. And the anterior approach is now tied with, if not more popular than the posterior approach. And this is not growing because patients are marketing it. It's growing because patients are demanding it. And I believe that this will continue the trajectory because simply on all facets, it is better. I appreciate your attention. Thanks, guys.
Bill, thank you. Hany, going to turn it over to you for your top 5.
Yeah, that's great. Great section. Thanks. I'll be really quick because we are getting late in the evening. Great. So I asked my fellows last week, what are my top 5 moves? Because they've seen a lot of people operate, and this is what they came up with. So if it's helpful, I'm glad. If it's not, sorry. But number 1 move, I tell everybody in the office that their leg is going to feel long, and that just sets the expectations. It drives you nuts when you get a post-op X-ray. It's absolutely perfect. Their leg lengths are spot on, and they are still complaining that their leg feels long. Obviously, it's just the delta between where they started with usually short leg lengths because of their disease and where you end up over the course of the hour in their total hip. So I set that expectation really early on. They all say, yes, it does feel a little bit long despite it being equal. The doctor said it was going to be that way. And then when the therapists come and tell them that their leg is long and the doc did something wrong, they say, no, he didn't. He did a good job. So does it help me? Absolutely. Second thing, I think somebody said this on the chat. How do you put your cups in? I use a highly porous, very sticky cup. We used to put them in under ream by 2. That was a problem. We had 1 or 2 fractures. I started doing them line to line with screws. And then we went back and actually measured the variability in the cup position. Same surgeon, it was just me. Same cup, same technique. The only thing that was different was the way that we reamed it. And you see the graphs there, the faint gray lines are the under reamed by 2 technique, both for abduction and anteversion. And the dark black line is our line-to-line technique. And you can see that even with the line-to-line technique, there's a little bit of variability there, but it's much, much tighter than with our press fit 2 millimeter technique. So does this help? Yes, the stress level drops amazingly by a significant amount when you can put the cup exactly where you want. You sort of pound it in and it goes exactly where you intend it to go, and it's not pushed in one direction or the other by sort of your ream or your hoop stresses. Number 3, I know a lot of people hate bone wax. I never did this before the last couple of years. I always was annoyed by when I made my osteotomy and then the femoral canal would just ooze and drain into the socket and constantly suctioning the socket as we were preparing the acetabulum. So I started just waxing the osteotomy site. I hadn't had any problems with increased infection. The only thing I would say is that you got to make sure you get all the bone wax out. We had one piece of wax that was caught in the articulation. The patient felt like their hip was sticky, believe it or not, and then when it spit out, they were fine. I think that this has brought our blood loss down pretty significantly. It's pretty unusual to have a blood loss more than 100 cc's. So this has been really helpful. I don't have any data to support it, but I still use it. Retractors, again, one of the things the fellows noted, I use retractors to hold retractors. I know that's not a novel concept, but when I'm operating down at the MGH, they don't afford us a lot of help. So these are my acetabular retractors. It's a left hip, it's a posterior approach. I put the self-retaining retractor against the other 2 retractors. And then basically nobody has to hold any retractors. So I can operate, the fellow can operate, I can hold the fellow's hand while he operates. So this has been incredibly helpful and low cost, no brainer. Doesn't really cost anybody anything. And then the final thing, this may generate some questions, but anyway, I started taking my highly porous acetabulum component and submerging it and dunking it in our multimodal joint mix, our anesthetic solution, before I implanted it. So it would sort of soak up this anesthetic and imbibe the anesthetic in the pores of the cup, and then we bang it in. And then that was that. And then we looked back to see if it really did help at all. And it seemed to. I mean, these are opioid usage rates. The blue curve is the control. So that was just putting the cup in as it comes out of the container. And then the orange is actually after we dunked it in solution, and the x-axis is time. And so you can see as time goes on, it seems to be a little bit beneficial if you deliver the anesthetic through the cup. The pain scores that we looked at, the VAS pain scores, were almost identical to these curves. And then the question everybody's going to ask is, do you have high incidence of cup loosening based on this? And the answer is no. No cup loosenings in the last 3 years that I've been doing this. So I think that this helps. I think this is real. But anyway, I hope that this helps, and great talk.
Hany, thanks. Great topics. We're going to circle back at the very end for questions for everybody. Sam, you're up.
All right. This isn't too much of a surprise. I'm not trying to just be the one guy screaming while everybody else is doing something else, but we kind of covered this in the first talk. I just think this works for me. So, and to the point about precautions and all that, I basically stopped precautions. I'm trying to put my money where my mouth is. So we'll see how that goes. But the data on precautions is pretty soft anyway. So anatomic hip closure, obviously part of that, and have covered that. 550 hips, no dislocations. I'm not here to tell you that there won't be any more dislocations. I just think it's gotten down to sort of the freak accident kind of incidents, which is about the best you can hope for. And to Hamilton's point about the approaches, I think, that ACA survey was 350 people this year. So I think let's get a full survey, but you're right, it keeps coming up. So socket navigation, I think Bill's point about using some sort of adjunctive technology for your cup placement, I totally agree with. I actually kind of do belt and suspenders. I do this intraoperative tool on most cases. It's just a matter of, what patients can actually get a CT scan sort of logistically. It's probably about 2/3 of my hips get this, and it gives me a nice sort of 3-minute intraoperative tool. Very, basically plus or minus 5 degrees. Tim Randall did that study with us when he was a fellow. Nice little computer interface that you can adjust the plan with. I also get intraoperative x-rays because offset, et cetera, and because it's just so sort of grooved at our hospital, it doesn't add much time. We've been doing it forever. So I do agree on some sort of imaging for positioning, offset, et cetera. So this is kind of goes to what Hany said. So leg lengths, checks, and balances. Obviously template. Dr. Hofmann drills this home, and I think it's really important. And then I have this little routine when I'm out and I say, hello, I'm going to mark your hip and blah, blah, blah. And I look at their feet and I check how long I think their legs are while they're sitting supine, because I may not see them supine in the operating room. And I ask them about their own perception of their leg lengths. And I try to get some sort of cross-reference between what they think and what the x-ray shows and what I'm seeing when I'm looking at their feet. And then I warn them before they get any medicine that it might feel long for a month or two. But it won't feel long forever. And basically, since we stopped sending people to therapy for hips, the leg length discrepancy rate's gone down by about 10-fold. When you're in the OR, then I check the heel pads or anterior knees, and I sort of again cross-reference that with what I saw, and then I decide, okay, it's 1 finger breadth difference between heel pads at the start of the case, and I want it to be half a finger breadth at the end, and that gets us within a few millimeters. And then I'm not into all these toxic chemicals, vinegar, bleach, soap, iodine, and I definitely don't like using any sort of pressurized irrigation on primary hips. There's this flow study. This was a totally different scenario. These are open wound trauma, but they found that a high pressure irrigation was not as good for soft tissues as low pressure. So I just use bulb, normal saline periodically, and that's that. Thank you.
Sam, thank you. And last but certainly not least, Houston, will you give us your top 5 moves?
Absolutely. So I learned a lot and carried over what Sam Wellman did at Duke when I trained underneath him. So a lot of this is all of his same techniques. And one of the slides is very similar about leg length, but I think he does a great posterior hip. And I've really enjoyed the technique and been very happy. top 5 moves. So no disclosures. Templating, obviously, this is huge. This is a case that we did today. If I'd like to do PowerPoints at the last minute. So today I'll run you through a case, pretty much covers all 5 of my top 5 moves. The fellow templated the left side. I would have medialized that cup a little bit more, but an important thing here is her operative right hip. If you see, and I take it from the obturator, the teardrops, and move it down. I really don't depend on the ischial tuberosities as much. I don't think that's as accurate, but she's already about a millimeter longer on the right side. So I know that when I'm in the operating room, if I didn't have that, I might shorten her to make her not feel as long, and then maybe she's unstable. You can see on the right side, I think we did a pretty good job. Maybe gave her 1 millimeter length for the amount of arthritis she did lose, and came up pretty accurate. Now let's go to checking leg lengths. I got this from Dr. Wellman, and it only is relevant if you do it before surgery. So I always tell my fellow who's right there on the left side, check the leg lengths, the heel pad, the knees. And it's hard to see, but in this middle picture, if you look, the knee is actually longer on her operative side, which is usually a little bit shorter. And so this coordinated well with the x-rays and was kind of interesting. Now this lined up pretty well. And if you check her heel pads, it's slightly longer. So I do have a good baseline that I know I'm not going to be lengthening her if I'm having problems with my x-rays intra-op, if there's any confusion, soft tissue issues, or I can't see the trochanters. It's another double check. I really consider it part of templating. Now, what happens when you have a femoral neck fracture? I think this is very relevant. A lot of people don't template because we don't have a marker. You could sure go get the quarter, put it between their legs or near the trochanter, try to use that in your system. But again, the advantage of our least program, we have a lot of CT scans. So I think a really quick, easy way is get that CT scan if you have it available. Like you see at the bottom of the image, get the diameter, and then take that diameter and put it back into TraumaCAD and get use that as basically your marker for the femoral head, and you're able to size up. This guy did on the right side about a couple of weeks ago, did that same. He came out really well, and it was important for this because it doesn't look like a huge femur. It's maybe a BC, but that's a size 22 taper lock. They don't get any bigger than that, so I knew I was going to be okay. So it worked out with a 48 head. So very interesting. Pegboard, big believer in the pegboard. So I always use the Wixom. And funny story at Duke was I was with Bolo, and I was working out then. I was in shape, getting out by 5 o'clock, going to the gym. I was strong, and when you ever have those Wixom, I was torquing on that screw to make sure it was stable. And one day the posterior one popped out, and Bolo looked at me like, "What the hell did you do, man?" I'm like, "Hey, trust me, I put it in there strong." And I kid you not, the next week I made sure both the anterior and posterior were double tight. I even got a wrench, and both of them popped off intraoperatively. I felt like a fool, but I had to tell them, like, I swear I tightened these. So after that, I said, man, I'm going to the pegboard. And since we were doing the ABMS, this is the ABMS board, but it took 6 months for them to get it in my first year of practice. So I started posterior. I think it's a robust. The hip doesn't move. Pelvis does not rotate. I really like it. So I really do believe in a pegboard. Preemptive strike, those trochanteric vessels, when you internally rotate and right before you can take your finger underneath the abductors and you find your piriformis, what I do is that soft tissue, you can see more on the right, I grab it with my pickups and just start hitting it, and you'll hear a ton of popping. That just prevents you from having all those little small bleeders that you can't see all the time. And that really cuts down on blood loss for me. Lastly, the retractors. I've got Big Daddy. It's the one in the middle on the top right. That really goes right underneath the trochanter. Gives you great exposure. Be careful on little old ladies because sometimes it can really hurt the soft tissues more by the lesser if you need to make a low neck cut. The far right, that's your standard Mueller. And the far left, that's your number 2 or your baby. It kind of looks like the baby we use in fellowship for your knees. And what that does, if you look at the far left, this is the trochanter from the posterior approach. This is the case today. I take that, basically hug go parallel with the trochanter, turn the corner, pop it in, and now I take my capsule, any of the abductors, if they've got a big abductor that's coming over, and I can now see straight down to where that really nice cortical bone is, so I can get my reamer, which is probably my 6th move I didn't have on here, to lateralize and thou shall not put into varus. And lastly, this is important. I think this video will play. This is today. Make sure you do a little move and a yell. Make sure everybody knows you did a good job. There you go.
Houston, that last slide is definitely the best tip I think I've seen. One question, Hany. There's a lot of talk about you're soaking your cups in juice. How long do you put it in there for, and what's the juice made of? Is it just pure local, or is it everything, Toradol, steroids, everything you got in the bucket?
It's everything, Tom. It's got the Toradol and the ropivacaine, and you put the cup in. It's only about a 20-second dip. You sort of shake it a little bit to get the bubbles out, so you get all the fluid in the cup, and you put it in. So I don't know. It seems to work for me.
Perfect. Well, gentlemen, I want to thank you, and also want to thank our sponsors for tonight: Total Joint Orthopedics, the Hofmann Arthritis Institute, Avanos, and Harris for providing support for this evening. And with that, thank you guys for joining us, and have a great evening and a wonderful weekend. Good night.